Hi, this is Pat Dillon. This video will depict the complete assessment that you need to do at the end of this course. So first you're going to begin by washing your hands and introducing yourself to your patient. Hi Zaire, I'm Pat. I'm going to do a complete physical exam on you. And if at any point anything hurts, you just let me know, okay? All right, so remember to start head to toe, work side to side, and focus in as if you're doing one area, complete everything in that area, because if you think you'll come back to it, I'm going to let you know from experience you'll probably forget. All right, so I'm going to look and palpate at the same time. I'm looking at size and shape of the head. The head is erect, it's midline, it's normal cephalic. Anything hurt? No. Okay, so since I'm palpating the head, I'm going to palpate everything I need on the face and on the neck. So I'll do my sinuses. Does that hurt? Those are my frontal sinuses, my maxillary. Does that hurt?
No.
I'm going to palpate the ear, the tragus, the mastoid. Pull the helix forward. I'm going to palpate the temporal arteries. Okay. I'm going to palpate my lymph nodes. So remember, use the circular motion of your three fingers. My occipital, my postauricular, my preauricular, slide down the angle of the jaw, my tonsillar, go a little one there, okay, my submandibular and my submental. Then what I'm going to do is come down from the tonsillar, my superficial cervical, go in the posterior triangle, get my posterior, do my deep ones, and then my supraclavicular. Okay. So the other thing I want you to do, can you bend your neck? Can you hyperextend, put your neck back? Can you turn left and right? Okay, and then can you touch your ear to your shoulder? That's it, good. And then the other. So it's full range of motion. Now this time I'm going to ask you to push up. Okay, and then push against and push against. Okay, so that tells me the 11th cranial nerve is intact. And since I'm palpating the neck, I'm also going to do palpate my carotids, one at a time. Then I'm going to also look at the thyroid. So the thyroid, you look at it in a neutral position, and could you tilt your head back? Could you swallow for me? Okay, good. And then all I'm going to do is try and palpate the thyroid. So I'm going to tilt you a little to the right, and I'm going to landmark by my cricoid, and I'm going to ask you to take a swallow. Now I'm going to tilt you to the left, landmark with my left, and then ask you to swallow. Okay, very good. All right, so we got everything in terms of palpation on the face and the head. So the other thing I want to do is test the trigeminal nerve for sensory, and so that is the three branches on the face. So I'm going to ask you to close your eyes. Tell me if you feel this. So it's forehead, cheek, and chin. Okay. All right. And now what I think I will do is we'll start with the olfactory. So we're going to check the nose. Any trouble breathing? No, I'm going to include one. Can you breathe? Okay, good. The other? Okay, good. And so what I'm going to do is check the olfactory nerve. And so we're going to use a distinct odor for the patient to smell. So close your eyes and cover one nostril. Tell me what you smell.
Mint.
Yes. Okay, good. Let's do the other nostril. You smell that? I think vanilla is supposed to be. So I think it's probably a little old. So you would use a distinct scent for each nostril. All right, so the other thing you want to do with the nose is take a look at the nasal mucosa. And so we're going to use the otoscope, and we're just going to see if The septum is intact, and let me take a peek. And what the color, and it should be pink. And we've got pink, okay, good. All right, so now I think I'll do the ears. So the ears, we're going to check our hearing, and so we're going to do our hearing test. So we're going to begin with the whisper test. So can you cover your left ear for me? And tell me what I'm saying.
Football.
Okay, now let me go over here. Cover the opposite ear.
Baseball.
Should have said basketball, right? Basketball season. All right, so now we're going to do our hearing test. So I'm going to take the tuning fork and I'm going to place it here. And tell me if you hear it equally in both ears. This is the Weber test.
Yes.
Okay, good. So once you do the Weber, then you're going to do the Rhine. And with the Rhine, you're comparing bone conduction and air conduction. And remember, air conduction is twice as long as bone conduction. So I'm going to put it back here. Tell me when you stop hearing. And now it's the sound's being transmitted through bone to the inner ear.
Okay, stop.
Now, do you still hear it? Tell me when it stops. So you would time this, and as I said, it's normally twice as long as bone conduction. Oh, is it good?
Okay, stop.
Okay, good. And you do the same with the other ear. Okay, tell me when it stops.
Okay, stop.
Still hear it? Tell me when it stops.
Okay, stop.
Good. All right, so air conduction was longer than bone, so that was normal. Now, before we look inside the ear, we're going to just again palpate those areas. Does anything hurt?
No.
The ears are made of cartilage, so they should be soft and pliable. Okay, so what I'm going to ask you to do is tilt your head a little and look before you insert gently. And remember, don't move the otoscope as much as pulling the ear up and back for an adult. And you have a perfect tympanic membrane and the ear canal is clear. Let's do this one. Tilt this way. And we already palpated, so we know those areas don't hurt. And another perfect drum. And remember, the normal color of a drum is pearly gray. All right, so now we've done the ears, let's do the eyes. So for the eyes, we're going to do visual acuity. Do you wear glasses or contacts?
Yeah, both.
You have your contacts in? Okay, and that's fine. Just note that you've tested with the contacts in. You're going to test each eye separately. So for visual acuity, we're going to do the Snellen eye chart, or we can use a pocket vision screener, which is a scaled down version of the Snellen eye chart. So you can hold this. For this one, you'll hold 14 inches away and cover your left eye. And can you read, probably better than me, can you read this line?
9, 3, 7, 8, 2, 6.
Okay, can you read the next line? Maybe a little blurry.
6, 2, 8, 7, 2, or 3, 9.
Okay, and then switch eyes. And that would be 20/20 in that eye.
Same line.
9.
9, 3, 7, 8, 2, 6. 6, 3, 8, 7, 2, 9.
Okay, so you had one mistake in that line, but you're allowed 2 mistakes. So I would say 20/20. You can also do both eyes together. I would do that if there was a deficit noted in one eye, because the 2 eyes together may compensate and you may come out with 20/20. Okay, good. Right, the other thing you want to do is check peripheral vision. So to check peripheral vision, you're doing it on a vertical field and a horizontal field. So there's several ways to do this. So could you cover your left eye, look straight at me, and tell me when you see my fingers coming in.
See it.
Tell me when.
See it.
Tell me when.
See it.
Okay, switch the other eye. Tell me when.
See it.
Tell me when.
See it.
Tell me when.
See it.
Okay. There's a small field located nasally, so look straight again, that you could get, okay? And that would tell me peripheral vision is intact in all fields. The other thing you want to do is near vision. So for near vision, you can have the patient read. So could you read this top line for me, please?
Practicum exam performance checklist.
Okay, so near vision intact too. So near, far, and peripheral vision is intact. So now we're going to do our EOMs, extraocular muscles or movements. Okay, so what I'm going to ask you to do is just look at me first. And what I'm looking for to see if your eyes are in parallel alignment, and they are. And I see the sparkle in your eye, and it's in the same place. So that's your corneal light reflex. So now what I want you to do is follow my finger, but don't move your head. Follow with your eyes. Okay, we're going to go up, over, down, up, over, down. Okay, now follow my finger in, and this is your test for accommodation. Okay, good. All right, now I'm going to check your pupils. Okay, good. Okay, so look straight at me. So when we check pupils, we're going to check for direct and consensual reaction. The direct means that the eye receiving the direct light will constrict, which you expect. The consensual reaction is that the opposite eye also does the same thing because your eyes work together. So let me take a peek. Okay, good. Now I'm going to do it again because your eyes are dark and it's a little hard to see. Okay, good. And good. All right, very good. All right, so the other thing you want to do is examine the external structures of the eyes. So you're going to take a look at the lids, the lashes. I'm going to ask you to look up. The conjunctiva should be pink. The sclera is white. No irregularities at all. And nothing hurts? You already palpated on there. Okay, good. So the last thing for the eyes that you want to do is use your ophthalmoscope. So usually you do this in a darkened room. And we need you to identify the red light reflex. So what you're going to use is the smallest white light that is on the ophthalmoscope. And you're going to set your diopter wheel at 0, like looking through glass. Okay, there we go. And you're going to do same eye, same eye. So I'm going to ask you to look straight ahead. And what I'm going to do is shine this right on your pupil, and it should reflect the light off the back of your retina. And there we go. And then you're going to do the same thing, the left eye, but this time you use your left to left. So again, the same thing. Okay, good. All right. Okay, so now we've done everything with the eyes. There's one last thing we can do, but for your lab practicum, I'm not going to have you do it, and that's the corneal reflex. So the corneal reflex is usually done on unresponsive patients. And the way that you do it is a protective reflex that the eye would blink and tear. If you touch the cornea is extremely sensitive. So you'd get a wisp of cotton and touch the cornea. So I hesitate to do that on patients because if you repeatedly touch the cornea, you may scratch the cornea. So there's an alternate way to do that, and that is to get an empty needleless syringe and just sort of puff air across. And puff air across will cause the eye to also blink. Another technique you can use is just, I'm going to run my finger over your lashes, and again, that would cause the eyes to blink. So that's how you can test for that. Okay, so now we're going to take a look inside the mouth. And before I do that, I'm going to ask you to smile. Show me your teeth. Okay, teeth are, it's good occlusion, and they're nice and white. But what I'm going to test is the facial nerve, and it's all motor, so I'm going to ask you to make faces. So can you puff out your cheeks, raise your eyebrows, frown, okay? And that would tell you that the facial nerve is intact. Okay, so now we're going to take a look inside. So I'm going to ask you to open up, say ah. Do it again, stick your tongue in, that's it. I don't want to gag you. So the gag is listed on your exam, but you do not need to gag the patient you bring in to do. You can just tell me how you would do that. The symmetrical rise of the uvula is your 9th to 10th cranial nerve, so is the gag reflex. So their ability to swallow and talk also contribute to that, so that would be intact. So open up again, and we'll just look over here, and we'll look over here. Okay, and we'll look at the hard and soft palate. Okay, now what I'm going to ask you to do is bite down on the tongue blade, and don't let me pull. Good. Okay, open up, bite down, open up. Okay, so we tested the sensory portion of the trigeminal. The muscles of mastication is the motor portion of the trigeminal, so we just got that too. So we're doing really good with our cranial nerves. We have one more thing to do with our cranial nerves, and that was to ask you to stick your tongue out, move it all around, left, right, up, down, and push out, okay, and push out on this side. Very good. So that's your hypoglossal. And the other thing, the hypoglossal, you might want to have them say, you can't teach an old dog new tricks.
You can't teach an old dog new tricks.
Okay, because there's certain letters, if there's trouble with the 12th cranial nerve, D, L, N, and T, they'll have difficulty pronouncing them. So you did just fine. Okay, so I think we're done on the top. I think we've got everything. So the other thing, since we're moving down, and we did the thyroid, we did our carotids, but what I can have them do is I'm going to listen to the carotids. So what I'm going to ask you to do is hold your breath, breathe, hold your breath, and breathe. Okay, so what I'm listening for are any bruits over the carotids, because you palpate them to see if they're present, and you palpate them for thrills. If there were a thrill, then you'd hear a bruit. So you have them hold their breath, because if you don't, then all you'll hear are bronchial breath sounds. So if there were a bruit, you wouldn't be able to detect it. All right, so before I begin the chest, I'm going to do some things on the arms. So let's check your pulses. My brachial. And the key to feeling pulses is arteries are elastic, so you need to back them into something firm, which is usually the bone. Great, +2. My radials. +2, my ulnars. Okay, good. And there's a test that you need to do, and it's called the Allen's test, and it's to check circulation in the hand from the radial and the ulnar arteries. And so what I'm going to ask you to do is first open your hand, and it's nice and pink. Now I'm going to ask you to close it, make a fist. And now I want you to open it, and then I'm going to release on one, and the color returns. Good. Let's do it again. And open, and the color returns. So you check each artery for patency, and that's called the Allen's test. Okay, so the other thing I want you to do is, let's see, put your arms up like this. Okay, good. Don't let me pull. Okay, good. Push against me. Whoa, okay, good. Much stronger than me. Okay, I'm going to ask you to squeeze my fingers as tight as you can. Go ahead. Okay, good hand grips. Okay, great. So we're going to do some range of motion of your arms. So can you raise your hands up? And then can you scratch? Scratch. Okay. And can you make circles? Okay, good. All right, and we already flexed your arms and extend. Can you supinate, pronate? Okay. Can you move your fingers in or open, adduct? Make circles with your wrist. Okay, great. And you're gonna inspect the fingers and the joints to see if there's any inflammation, nodules, any tenderness. You're gonna feel the muscle mass in a relaxed state, and there is good tone. Now I want you to contract, and there's great tone. Okay, great. Okay, so now we're gonna do some sensory things. So what I'm gonna do is ask you to close your eyes. So, before you close your eyes, I'm going to tell you, this will be soft, this will be sharp, okay? So we're going to do superficial sensation. So there's light touch, pain, and temperature. We're just going to do light touch and pain. Temperature and pain run along the same track, so you either do pain or temperature. So for adults, usually you do something sharp. So close your eyes, and we're going to randomly compare side to side.
Soft. Soft. Sharp. 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 Sharp.
Okay.
Sharp. Soft.
Okay. And remember, for superficial ones, you can't assume that if it's intact distally, it's intact all the way up. Okay, there's a couple other sensory things you're going to do. There's deep sensation. So what I'm going to do is take a tuning fork, and I'm going to place it on a knuckle, and I want you to close your eyes and tell me if you feel it when it stops. Feel it?
Stops. Feel it. Stop.
Okay, good. All right, and that is called a vibratory sensation. That's a deep sensation. The other deep sensation is proprioception or position sense. So I'm going to move your finger, and you tell me which direction am I moving it in. Close your eyes.
Up. Down.
Okay, let me do this.
Down. Up.
Okay, and again, for the deep sensations, if they're intact distally, they're intact all the way up, so no need to go further. And we'll do the legs in a minute. Now there are some discriminating sensations that we want to test for. So we have what we call 2-point discrimination. So it's the patient's ability to discern if they're feeling 1 or 2 points. So tell me if it's 1 or 2.
1, 2, 2, 1, 1,
Okay, turn around.
2, 2, 1.
Okay. And depending on where you test will depend on how well they can discriminate. Your fingertips are the most discriminating, so they're usually will be within a millimeter or so on that area when you test that, where you can be a centimeter or more apart on the forearm. 1 or 2.
1, 2, 2, 2.
And you can see as I go closer down to the hand, the ability to discriminate is better.
2, 1.
So we're within millimeters on the fingers. Okay, so there's a couple more that we're going to do. So I'm going to put something in your hand, and I want you to tell me what it is. Hang on, close those eyes. Okay, so I'm putting something in your hand. See if you can tell me what that is.
A coin.
Correct, okay. Now, give me your other hand. Something in this hand.
A paper clip.
Correct. So that is called stereognosis. And then we're going to do graphesthesia. So for graphesthesia, you're going to write a letter or a number in their hand. So I'm going to do a number and let the patient know what you're doing. Okay, so tell me what this is.
8.
Okay, let's do something, and we'll do a letter.
B.
Correct. And that one is called graphesthesia. The easy way to remember it, writing graphic, that's how I remember that one. So there's one more that I want to do, and that's called extinction. This is part of the stroke NIH scale. So I'm going to touch the patient on opposite sides of their body and ask them if they can identify. So close your eyes and then point to where I touch. There you go. Okay, and we'll do it again. Very good. Okay, great. Now, we're gonna move down. We'll do, since we're doing sensory, we might as well finish up on the legs. So we did some range of motion of the legs, so we'll do the rest when we're lying down, but we'll do our sensory. So again, this will be light touch, this will be sharp, okay? So close your eyes. Tell me sharp or dull.
Dull. Dull. Sharp. Sharp. Dull. 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 Sharp. Sharp. Sharp.
Okay, take your socks off. Okay, good.
Sharp. Dull. Dull.
Okay. All right. And then we're gonna do our deep sensations too on the lower extremity, so we do the vibratory. So we're gonna place this on a toe. Tell me if you feel it.
Feel it.
Tell me if it stops.
Stop.
Tell me if you feel it.
Feel it. Stop.
Great. So vibratory sensation is intact, and the last one we're gonna do for deep sensation is position. I'm gonna move your toe, tell me if it's up or down.
Up. Down. Down. Up.
Okay, good. So deep sensation and superficial sensations are intact. Okay, so now what I'm gonna do, I think we got everything there. We're gonna take a look at your chest if that's okay. So let's slide your arms out for a minute. Okay, so now part of your exam has to include the breast exam. So when you do the breast exam, you have to do it in a couple of positions, or inspect the breast in a couple positions. So I'm going to ask you to put your hands up again. Okay, great. And what you're doing when you do these maneuvers, put them down, and then push on your hips. Okay, great. And what you're doing is trying to see if there's any underlying mass that may become evident when you do these maneuvers. And pushing on the hips contracts the pectoral muscle, so if there's an underlying mass, it'll sort of cause dimpling or retraction of the tissue. So I don't see any of that. So in the front, we're going to do our respiratory assessment. So we're going to look at the size and shape of the chest, and it seems a 1-to-2 ratio. And basically in the front, you're going to palpate, and then you're going to percuss and listen. So any areas hurt? Okay, great. So we're going to percuss. Remember, the lungs start above the clavicle. Now, particularly when you get to the third interspace, you're over the heart on the left, then you're over breast tissue, especially on a woman. So usually I say that the anterior approach gives you better access to the upper lobes. But remember this too, that the right lung has the right middle lobe, and the only way you have access to the right middle lobe is from the anterior approach or the lateral approach. You can't get to it from the back. So we percuss. Now we're going to listen. And you need the diaphragm, and just ask the patient to breathe nice and slow in and out. Okay, good. So his lungs are clear and he had resonance equal bilaterally. Now, you can do a cardiac exam in a sitting position or in a supine position. So for the years since he's sitting, for a man it's easy to do in a sitting position. For a woman, if breast tissue is an issue, probably supine will be best. So we'll do the cardiac in a sitting position. So we're going to find our site. So we're going to put our finger above the clavicle, roll into the first inner space there. Here's 1, 2, 3, 4, 5. And we're going to use inspection and palpation to look at these sides and then feel in these sides. And we're going to see if we feel the PMI, which I do on Zaire. And if you feel it, you want to estimate the size. PMI stands for point of maximum impulse or left ventricular impulse. So Zaire's is nice and strong, and it's 2 centimeters or 2 fingers, and that's normal. Okay, so then I'm going to come over and place my hand here on the left lateral sternal border to see if I feel pulsation. And remember, this is your powerhouse, so the further you go away from the apex of the heart, then less likely pulsations will be palpable, and I don't feel them here. So this would be my LLSB or tricuspid area. 1, 2, here's base left pulmonic, and here's base right aortic. So this is your quiet area, so you don't want to see large pulsations in this area, because that would not be normal. So you're going to listen with both the bell and the diaphragm, and since my stethoscope is pressure sensitive, I can go heavy light. So I'm going to listen. And I go heavy, then light. And there's 2 positions we have noted on for your lab practicum, and that is that one that you have the patient lean forward, listening at left lateral sternal border. That's good for friction rubs. It's also good if you're having difficulty hearing heart sounds on a patient, and that typically happens with obese patients or patients with COPD. Having them lean forward brings the heart more anterior, making it easier for you to hear. All right, so we've done cardiac, we've done respiratory, we've done musculoskeletal on the upper. After you assess the lungs in the front, the back really will give you the best view of the lungs, because there's nothing really to get in your way. So you're going to use all 4 techniques of physical assessment. So I'm going to begin by looking, and I'm also going to feel. Anything hurt? Okay, so what I'm going to do is feel for respiratory excursion. So I'm going to ask you to take a deep breath. And he has great excursion. So if you have equal excursion at the base, then you don't need to move up the chest. Then I'm also going to palpate for tactile fremitus. So I want you to say 99, 99, 99, 99, 99, 99. Okay, so he has equal tactile fremitus. Now what I'm going to do is percuss the lungs. And you should get resonance. To about T10, and remember, this puts you at 8, 9, 10, so we're right at 10. So he has resonance equally symmetrically to T10. So you can further assess respiratory excursion. So what I want you to do is take a deep breath in and blow it out and hold. Blow it out and hold. Okay, breathe. So we would make a little mark here, and what we're going to do is measure. You can breathe. Okay, so this time I want you to take a deep breath in and hold. Okay, so that's, you can breathe. There's your diaphragmatic excursion. So the drop usually is about 2 inches or about 5 centimeters, and we got 5 centimeters. So when your lungs fully expand, they'll drop to T12, and you would do the same thing on the other side. So after you percuss and we've inspected and palpate, you're going to listen. So just breathe normally. Remember to start up high, because you're in the back. Bend your head for me for 1 second. Your lungs start at right below C7, which is T1. So here's your most prominent, which is C7. Here's T1. You start on either side. So just breathe regular. And when you listen, make sure you go 2 levels below the scapula so you get to your base. And always compare side to side. And if you haven't assessed the lateral sides of the lungs, you can do that now. And actually, this will give you better access to it. Okay, good. Now, there's one other thing on your lab practicum that you have to test for, which would not typically be tested unless you suspected that the patient had pneumonia, and they are called abnormal voice sounds. So if you just show me in 2 areas how to do this, this will be fine. So to check for egophony, I'm going to put my stethoscope on, and I'm going to ask the patient to say E-E-E. Say E-E-E. E-E-E. So that's egophony. So if there were consolidation, it would sound like A. Now this time I want you to say 1, 2, 3.
1, 2, 3.
And 1, 2, 3.
1, 2, 3.
Okay, and that's called bronchophony. So if I got clear transmission of voice sounds, that's called bronchophony. And again, that would be significant of consolidated lung tissue. Now this time I want you to whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3.
And over healthy lung tissue, it won't be discernible. But over consolidated lung tissue, it will be louder and clearer. And the other thing you can check while you're back here is for CVA tenderness. And so what I'm going to do is check the kidneys by a little tap. I'm going to give you a little tap. Tell me if it hurts.
No.
And that concludes the posterior approach to the respiratory. All right, so we've done cardiac, we've done respiratory, we've done musculoskeletal on the upper, and I think we're good. So what I want you to do is if you could lie down for me. And we'll do the breast exam. So the breast exam is typically done routinely on women, maybe not as routinely on men, but men do get breast cancer. About 1% of men get breast cancer. So you still need to do the examination. And so when men get breast cancer, it's usually around the areolar tissue or around the nipple. When women get breast cancer, it's usually in the upper outer quadrant. So when you do your examination, we've already inspected the breast. But what we're going to do is we're going to palpate now, and we want to go from below the clavicle, from the mid-sternal to mid-axillary, and we want to make sure we cover this whole area. You're going to use light pressure, a little deeper than really deep, depending on how dense the breast tissue is. You want to take their arm and put it above their head, and you just gently palpate. And if anything hurts you, let me know. And you work your way across the breast tissue. And usually the last thing you want to do is palpate the nipple. There should be no spontaneous discharge from the nipple in postmenopausal women. The only time you get spontaneous discharge from the breast is if the person is lactating. And even in premenopausal, you shouldn't have any discharge unless they're lactating. The other thing you want to check are the lymph nodes. Are you ticklish? A little bit. Okay, so this can be done in a sitting or a supine position. You want to reach high up into the axilla for the central nodes. Then you're going to reach it towards the front, the anterior pectoral, and then you're going to reach to the back, which would be your scapular or posterior nodes. Then reach on the inside of your humerus, and these are your lateral nodes, and then reach around the elbow. These are your epitrochlear nodes. And you would do the same thing for the other side. So the other thing that's on your lab practicum is that you have to position the patient in the left lateral recumbent position. And this is good for picking up third and fourth heart sounds if they're present. And again, what it does, it brings the tip of that left ventricle more interior. So could you turn on your side a little bit to the left?
Okay.
Just a smidge. Perfect. Okay, so what I'm going to do is listen over here. And you're gonna listen with the bell, so I would hold lightly if I'm trying to pick up S3s and S4s. Because, again, they're diastolic ventricular filling sounds, that's fine. Okay, great. All right, so you can put this back on if you want, because we're done with the chest. And what we'll do is move down to the abdomen. Okay, good. Okay, so for the abdomen, we're going to inspect, and we're going to auscultate, and then we'll palpate and we'll percuss. Okay, so first we're going to look, and we're going to look from a couple different angles. I see respiratory movement. I see some pulsation. I don't see any peristalsis. Umbilicus is midline and inverted. There's no unusual discoloration. There's no lesions. The abdomen is flat and everything is intact. So remember, you have to listen before you palpate or percuss, because that may alter your bowel sound. So does anything hurt? No? So if nothing hurts, it doesn't matter where you start. So you're going to listen to each quadrant for your gurgle, gurgle, click, clicks. And remember, they should occur 5 to 15, 20 seconds. Okay, and then the other thing you have to listen for are bruits. So we're going to listen over the abdominal aorta and hold it lightly. Over my renal arteries. And then over my iliacs. And femoral or in the groin. So for your lab practicum, you don't need to feel the femoral and you don't have to feel the inguinal nodes, all right? Okay, so after you listen, then what we're going to do is we'll percuss. Just general. Okay, and then we're going to try and get a liver measurement. So we're going to do a right midclavicular line. And that would be my lower edge. And you could mark it, but I'm going to eyeball it. Okay, and then we're going to start it long. There we go. And the liver was 8 centimeters. And remember, normal liver span at the right midclavicular line was 6 to 12. If you want, you can use that scratch test that I showed you to find the lower edge. The other thing you need to do is percuss for the spleen. So I'm going to ask you to turn towards me just a smidge. Okay, good. Okay, so I'm going to find the last inner space. Okay, so now take a deep breath. And it doesn't change, so that's good. Because if it changed to dullness, it would tell you the spleen was enlarged. That's one way to find it, or you can look for an area of splenic dullness between the 9th, 10th, and 11th rib. So, right here. You can hear the dullness, okay? All right, so after we looked, we listened, and percussed, now we're going to palpate. So I'm going to just gently palpate. Tell me if anything hurts. So light palpation first. Again, if any other reason, put the patient at ease. Okay, and then we can go deeper. And then the other thing you have to do, you don't need to palpate the organs for this exam, but what you need to do is palpate, see if you palpate the aorta. And if you don't, that's okay, because you may not. But if you do, you want to estimate its size. Okay, and so for say here, there's one. It was about 2.5 centimeters, which is normal. Okay, great. All right, so now we're going to move down to the legs. So we're going to look and inspect and palpate. Skin is warm, dry, and intact. There's no unusual lesions. We're going to check our pulses. Dorsalis pedis, +2. Posterior tibs, +2. Popliteal. I would say they're probably the most difficult ones to find because there's a lot of soft tissue back there. Okay. And then what we're going to do is we've already done our sensory. So what we're going to do is some range of motion. So I'm going to ask you to flex your leg, bend it, and then turn in, turn out, and extend. Okay, and again, bend, turn in, turn out, extend. Okay, can you point your toes? And then bring them up? And can you make circles? Perfect. Okay, good. Can you push up against my hand? Whoop. Okay, good. Push up against this hand? Okay, great. Push against my hands? Okay, good. Pull against my hands? Wonderful. So we've done the strength of our lower extremities too. So there's one more thing that I want to check since I have you in this position, and I'm going to check for your plantar reflex. And so you can either use the back end of a hammer or you can use your thumbnail. So this is probably known best as a Babinski, but the reflex in itself is called the plantar. And for an adult, the normal plantar response should be that the toes curl down. Okay, so here we go. You ticklish? Okay, let's see. Not too bad. Okay, good. So that was really a negative plantar and a negative Babinski. So if nothing happens, that's okay. But you don't want the fanning of the toes, which would be a Babinski. So you start at the heel, go lateral, and then swing around, okay, to the great toe. And again, negative plantar, negative Babinski. Okay, so I think we're done with our lower extremities. So I'm going to ask you to sit up, okay, and we're going to stand you in a minute. But we have a couple more things we have to do for neuro. Okay, so what I want you to do is go like this. So these are things for cerebellar function. And can you tap your hands and go rapid alternating movements? Okay, great. Okay, now can you touch your finger to your nose? Close your eyes now. Okay, good. And another way you can do that, which is a little trickier, is open your eyes, touch my finger, then touch your nose. Okay, good. So these are accuracy of movement. So cerebellar function so far is pretty good. All right, so before we stand, we want to do our reflexes. Okay, so remember your deep tendon reflexes are graded on a scale of 0 to 4, with 4 and 0 being abnormal. This is your biceps. Okay, good. Okay, good. And your triceps is back here. Just relax your arm. Just let it drop. Dead weight. Okay, good. Let's do this one. Just let it hang. Okay, and then your brachioradialis. If you don't get the exact, that's a good one, response that you're looking for, as long as you're hitting in the right place, I'm good with that for you, for your lab practicum. Good, all right. Your patellar. There you go. And remember, if you're having difficulty, there's 2 reinforcement techniques you can use. You can have them clench their teeth or interlock their hand. Personally, I think they're just distraction techniques. And then the last one is your Achilles. Okay, and what you get is plantar flexion. Let's see if I can do it this way. Good. Okay, great. So your reflexes are intact and they're +2. Okay, so now I think we've done our strength, we've done our range of motion. What I'm going to ask you to do is stand. Okay, what I'm gonna do is ask you to turn around. I'm gonna look at your back. Now, one of the things that I should have done a little early is check for CVA tenderness. When they're on their side, you can do this. You're just gonna give them a little tap back here over the kidney area to check for tenderness. But when they're standing, you're gonna look at the back. You're gonna feel any tenderness? No? Okay, good. Can you bend over for me? Okay, so we're gonna, very good, perfect. No scoliosis here. Okay, come back up. Now, can you lean back a little? Perfect. Okay, turn towards me now. Can you go side to side? And can we twist? So now we have range of motion of the spine. And then the other thing I'm gonna ask you to do before I have you walk is, can you put your hold on here and then just put your hip back and then the other. Okay, now we've done range of motion completely on the legs. And now what I'm gonna ask you to do is stand there with your eyes open, feet together. Okay, good. So now we're gonna do the Romberg. Now close your eyes. Perfect. Okay, now can you put your hands out like you're holding pizza? Okay. All right, now close your eyes and I'm gonna tap. Okay, good. So that's your pronator drift. Okay, so now we're almost done. So what I want you to do is just walk over there a little bit, a few steps. Okay, and when you come back, turn around, and when you come back to heel to toe. Okay, good. Now when you go back, go on your tippy toes. And then when you go back, go on your heels. Okay, and a couple more things. Can you hop in place? Now on the other. And a little squat. Great. And that concludes our total exam. Thank you.